survival curve of patients who do not have CML. And this is males 55 years, females 55 years. And over a period of time, the overall survival of patients of CML has come to a point after, in this decade, that it is equal to or very close to patients, survival of patients who do not have CML. And this holds for patients aged 55, males, females, patients aged 65, males, females, patient age 75 males, females, 85 males, females. So we have in the vast majority of our patients with CML come to a point where most of them are having a life expectancy equal to the general population. But there are certain issues, and we know that looking at a problem is always a matter of perspective. This guy is looking at this figure and is sure that this is 6. This guy is equally sure that this is 9. So just because you are right doesn't mean that I am wrong, and you just haven't seen life's position from my perspective. And this is the perspective today for chronic myeloid leukemia in the developed countries. The treatment is more or less cut and dried. Most patients will have a near normal lifespan. Second generation tyrosine kinase are easily available even in the first line and certainly in the second line. And BCR-ABL monitoring is standard, approved by insurance. So they can get it done every 3 monthly or even more frequently if they so desire. They're good labs and it is covered by insurance. On the other hand, in our country and in other Asian countries, it is a challenge to provide standard of care treatment to most patients. Long-term outcomes still remains a question mark. Second generation TKIs, because of the cost, is difficult to arrange for the patient in the first line and sometimes also in the second line. And ideal monitoring, meaning getting a BCR-ABL done, a test which costs 6,000 to 7,000 rupees in our country, done every 3 months, is a reality in a very small minority of our patients. So these are the specific issues in our countries. They are economic issues, no medical insurance, about 70 to 80% payments are out-of-pocket payments. Patient has to travel long distances to get to the closest medical expert, to get to the closest laboratory. There are too few medical experts, too few oncologists, too few hematologists for the large number of patients which we deal with. And the number of qualified labs, again, are small in number, relatively far away. Transportation of samples is an issue. And we don't know what kind of quality controls they follow in their labs. Costs of the treatment, not only for chronic myeloid leukemia, for other diseases, other cancers, is becoming a big issue. And this was very eloquently highlighted in this publication in the Blood in 2013. Lots of us were part of this publication also. And even the most rich and the advanced countries are now talking of these evidence blocks in which affordability of a regime is being charted out, and that is figuring in the treatment decision making for so many cancers. And even the developed world has now realized that medical bills are really killing us, and they have come to a point where it might close to be unsustainable to give these very expensive medications to our patients. And we know that one acceptable way of reducing cost of treatment is the availability of generic drugs. And we are lucky in the sense that we have, of course, the first generation generic drug available, imatinib, available to us for since several years. We now also have several second generation TKIs. Dasatinib is now available in generic form. Bosutinib has recently been launched, but we are still waiting for generics of nilotinib, and even more importantly for the third generation TKI, ponatinib, which we don't have at the moment. The world has accepted that good quality generics is the way forward to reduce treatment costs. This has been accepted by the WHO, also by the US FDA. But the quality of the generic always remains a little bit of question mark. Is the generic medicine as effective, as pure, with as many side effects or less side effects as compared to the innovator, that question mark remains. And we've done a small study way back in 2014, published in the Leukemia Lymphoma, in which we, basically looked at the effectivity of imatinib and correlated with plasma trough levels. We did find a correlation between trough level and response. But the more important thing for us here is that we looked at plasma levels of Gleevec versus the generic imatinib, and there was no statistical difference between the two. So we are reasonably confident now that at least standard Indian generics, and all of us know which are the standard generic medicines, are as good as the innovator. So let's come to the case now. So I want you to take a pen and paper, note down carefully. We are talking about a relatively young 38-year-old male farmer by occupation, came to us in Jan 2013 with 4-month history of standard advanced CML, malaise, weakness, anorexia, plump left abdomen, 20 centimeter spleen, 9.2 hemoglobin, very high counts, 3,20,000. Increased platelet counts, shift to the left on the peripheral blood, 2% blast, 2% basophils, 4% eosinophils. The marrow was hypercellular, accelerated granulophysis, shift to the left, 4% blast. Cytogenetics 20 on 20 metaphases showed PH chromosome, and the BCR-ABL by RQ-PCR was 68.92%. His final diagnosis was myeloproliferative neoplasm, chronic myeloid leukemia, chronic phase, high focal risk, as well as high UTOS, as well as high HASFORD. Let me point out over here that we have a new score which you should be familiar with and start using. It is the ELTS, the UTOS long-term survival score. And my suggestion is that all new CML patients should have a SOCAL score at diagnosis, and also ELTS score. So now this patient, because he had high burden disease, was counseled to second generation TKI up front, which he categorically refused because of economic reasons. So we enrolled him in the GPAP program, got Gleevec available for him, started him on Gleevec 400 milligrams per day. Good response, hematological CR in 6 weeks time. He became asymptomatic. We got CBCs done every month, and we asked him to get a BCR-ABL done after 3 months, which he refused because he didn't have the money. But we did get a BCR-ABL done at 6 months, which showed an optimal response from 68, it reduced down to 2.68. So we continued the imatinib, kept monitoring his CBC every 2 to 3 months, and requested him to get a BCR-ABL done every 6 months. And you can see that over a period of time, he had a good response. He went into a deep molecular response by December 2015. So now this case brings up some special issues with dealing with CML patients in our part of the world and other low middle income countries. At presentation, the majority of our patients are younger, and they present in the 4th or the 5th decade of life rather than in the 6th and 7th decade of life, which is more true in the West. Fertility and this young age, particularly females being diagnosed in the 20s and the 30s with chronic myeloid leukemia, has its special problem of fertility and childbearing, and treatment-free remissions for these patients who are young becomes even more important because they are going to be exposed to the TKI for a long, long time, maybe 20, maybe 30 years, and the time where the long-term toxicities can kick in. Then the second point which this case brings up is that most of our patients, at least 50% of our patients, have high volume disease and advanced stage of disease at diagnosis. And ideally speaking, these are candidates for the second generation TKI because we know that these agents are more effective than the first generation. They produce a quicker, deeper response, particularly in patients who have high burden disease. But because of economic reasons, our patients can't afford this. So we are stuck with giving them first generation TKIs. And we know that low-cost imatinib used to be available to us through the GPAP program, but now the GPAP program has not is not enrolling any new patients for several years, but the drug is available in the government supply and it has made it into the essential drug list of most government hospitals. So a reasonable quality first generation TKI should be available to every single patient of CML today. Optimal and regular disease monitoring as per guidelines is not possible for the majority of our patients, like getting a BCR-ABL done every 3 months and then every 3 monthly is difficult because the test costs about 6,000-7,000 rupees and most of the patients can't arrange that money. Then half to 2/3 of the patients in our country are in so-called 2 or 3 at diagnosis. And as per the publications which we have from our country, we have lower rates of hematological, cytogenetic, and molecular responses. And my personal feeling and a feeling of a lot of experts is that this is because of advanced stages at presentation, just massive amount of disease at presentation, and not because of any biological factors, but still this remains to be confirmed. Then molecular monitoring is suboptimal because of economic reasons, but we have a huge number of patients because our population is huge. We have a really large number of patients. Chronic myeloid leukemia is the commonest adult leukemia in our country. Majority of the patients don't have an option of the second generation TKI, and the third generation TKI is not available in our country. And then stem cell transplant, again, because of costs, is an option of treatment for a very small minority of patients. So let's talk a little bit about prevalence of CML. When you want to find out the prevalence of any disease in any country, you need these 3 things. You need a population structure dynamics, you need the age and the sex specific incidence rates, and you need the year specific relative survival. So we have a little bit of data on all these 3 points for CML in our country. And if you extrapolate these 3 things to these curves, this is what you will come to, that by year 2030, we are going to have 150,000 patients of CML who will be on some or the other treatment. And this is some estimations done by my good friend Mark from Paris. So this huge number of patients are going to be there for us to take care of. We are going to have to find the number of hematologists and oncologists to take care of them. We're going to need to find ways and means to look at their toxicity profile, to look at TFRs in these patients, to look at monitoring in these patients. So we really, the government and us, we really truly need to gear up to deal with this massive number of patients. And this is the International Chronic Myeloid Leukemia Foundation, and they estimate that there will be more than 3 million patients worldwide in a few years' time, and a good half of them will be from India. So we know that these phases of CML, the chronic phase, the advanced phase, accelerated and blastic phase, in the high-income countries, my postulation is that they are diagnosed early in the course of the disease because of so many factors. They get their CBC done earlier, they do regular health checkups. But in our country, the low middle income countries, we diagnose them in the chronic phase, yes, but we diagnose them quite late in the chronic phase, where the genome has become a lot more unstable and there are a lot more subtle genetic abnormalities. And this is the reason why we have less hematological, cytogenetic, and molecular responses, and our patients don't do as well as what has been reported from the Western countries. So let's go back to our case. Imatinib was continued with 2 to 3 monthly monitoring, BCR-ABL every 6 months. He did well till December 2015, about 2.5 years after diagnosis. Then when we did his BCR-ABL in May 2016, we were shocked to see that he had lost the major molecular response. The BCR-ABL had risen to 1.32, more than 2 log increase. The last one was this, so more than 2 log increase. So we got another test repeated. In fact, he didn't have to pay for this. We got this, put some pressure on the lab and got this done free. It confirmed the same, that he had lost his molecular response. So after careful questioning of the patient and particularly his wife, I called his wife. I told him, go get your wife. I want to speak to her. We were able to elicit out, price out the history of non-compliance. The patient was omitting 7 days per week of meds per month for the past 3 to 4 months. And why was he doing it? When we asked him, he said that he was feeling well and normal, and he wanted to see if he could slowly stop the medications. So the major take-home point here for each one of us is that once we see that a patient is not doing well, losing a molecular response or losing a hematological response also sometimes, the number one thing to do is don't ask for a BCR-ABL kinase domain mutation analysis. Look at the compliance. And there have been various estimates of compliance in our country, ranges from between 20 to 40%. And there are several reasons. The one is that the patient feels so good that he kind of starts to think that he doesn't need the TKI. And of course, the second could be because of the side effects, which are not unsubstantial. The myalgias, arthralgias, general malaise with the medications makes them not take the medication. And this is one of the main reasons for suboptimal response. So once you guys graduate, become DMs, DNBs in medical oncology, hematology, go out into practice, you have a patient who's doing well and then suddenly loses response. This is the first thing you should do, check for compliance. And every time the patient comes and sees you, maybe every monthly or every 3 monthly or every 6 monthly, you re-emphasize to him every single time that it is vital for him or her to take the medicines regularly and not to miss even one dose of the medication. There is some data from the Hammersmith hospital in London that if the patient omits or misses just 2 pills a month, then that adversely affects the molecular response. So once you highlight to him कि कुछ भी हो जाए, आंधी, तूफान, दंगे, आपको medicine जरूर लेनी है. So it does actually help if you reinforce that again and again. So again, a little bit of repetition over here. Optimal monitoring is not done because of economic reasons. So we have issues with some private labs which don't give us a quality report. And what kind of internal quality control they do remains a question mark. We have very few top quality academic labs, say like the AIMS or Tata Hospital or excellent lab in Velo or excellent lab in Nizams. But these are actually far and few, and it is difficult to send samples to them. And then patient has to travel long distances for testing. This is a little eased because we have collection centers in most big cities now. So it is possible to send samples, but the main problem remains the cost. So can we in our countries, in the low middle income countries, can we simplify and improve on the BCR testing and sample transportation? There is some evidence, this has been around for a long time for infectious disease, but can you transfer blood on paper or plastic as dried blood spots? These can be stored and shipped by surface mail. And can you extract enough RNA from these dried blood spots? So this was a very early publication from my good friend Jerry Radish's lab in the Hutch, Seattle, in which they did find that even after storing the blood spots for a long period of time, in these 5 patients of CML, they could get adequate amounts of RNA. And this is Jerry, a very dear friend of mine, one of the top CML experts in the world. And this is what he does. He does these blood spots. He's done hundreds of patients from Africa now. We did a small study with him on these 10 patients. This BCR-ABL we did locally, and we did it on the CFED machine. So this is 100% accurate, very little intervention. And you can see that in this very preliminary study, and we sent the filter paper by surface mail to Jerry's lab in Seattle. And you can see that the age of the blood spots, 90 days, 125 days, 126 days. And other than this one sample in which there was discordance, most of the other samples, whether it be very low BCR-ABL or very high BCR-ABL. There was very good concordance. So this is something which is quite exciting for us. Jerry and his group are, taking this forward in Africa, and we have submitted a proposal for taking this dried blood spot testing and extraction of RNA from the dried blood spot. We are doing a little bit of work. We've got some funding for this also, and then maybe we'll show you some little bit of Indian data in about 12 months' time. So let's go back to our case. So we scolded him, we yelled at him, we told his wife stuff to be more compliant. He did that. He quickly regained his major molecular response. And then he lost the major molecular response again in 2018. So this is about 5 years after diagnosis. And after 3 months' time, we reconfirmed this. He did lose the molecular response. And this time he was 100% compliant. He was diagnosed as having molecular relapse of chronic myeloid leukemia resistance to imatinib. We got a BCR-ABL kinase domain. We asked him to get it done. He refused because this is an expensive test, costs about 15,000–20,000 rupees. So we offered him nilotinib or dasatinib, one of the second generation TKIs. You know that both these drugs are not available on compassionate ground. They're not available in the government supply. He would have had to spend about 9,000 rupees per month for nilotinib, about 16,000–17,000 rupees per month on dasatinib. And because of this expense, he kind of refused. The only option left for us was to increase the imatinib. We increased to 600, then to 800. He did not tolerate 800, so we got him back to 600. Unfortunately, with 600 milligrams, he did not show a major molecular response. He continued to be in complete hematological response. His BCR-ABL hovered between 2 and 10%, so he did not show a major molecular response. So now what are the learning points for us from our case till now? It is crucial to periodically monitor BCR-ABL every 3 monthly, preferably, but at least every 6 monthly, so that you can detect early molecular response, which we were able to do in our patient. And then kinase domain analysis is a must, so that you can choose, pardon my typo over here. And why should you get a kinase domain mutational analysis? Either by Sanger sequencing, some of us are now getting it done by an NGS, because it will help you choose your second or third generation TKI. Say for example, if your patient on kinase domain mutation analysis shows the T31, pardon me, shows the T315I mutation, then you know that your second generation TKIs, nilotinib and dasatinib, will not work. The only thing which will work for that patient is the third generation TKI, ponatinib. I don't know how you can lay your hands on that, but you would at least not waste time and money on the second generation TKIs. So post-imatinib progression, one of the second generation TKIs, dasatinib or nilotinib or bosutinib. We fortunately have bosutinib available in our country since the past 2–3 months. This remains the standard of care. For patients who can't afford this or can't arrange this, the only option left is increasing imatinib, which works in only 10% of patients. And for patients who are not candidates for either of these two or progress on either of these two, we must keep the possibility of stem cell transplantation in mind for the selected few. So in our case, when the patient could not afford the second generation TKI and imatinib 600 milligrams per day was not working, he was not tolerating 800 milligrams per day of imatinib, what did we do? We did something off the shelf. We added pioglitazone to his imatinib. Pioglitazone, if you remember your medicine, is an anti-diabetic drug, is a PPAR agonist, which is used in patients with diabetes. And lo and behold, he tolerated that medicine well. There were no hypoglycemias or hepatotoxicity, which is common with this drug seen in our patient. And he achieved a major molecular response in 6 or 9 months' time. And presently, our patient is on 600 milligrams of imatinib, 30 milligrams of pioglitazone. He is tolerating both well and is in deep molecular remission. So now where did this come from? Can we do funny things like that for some of our patients? So this is where the concept of targeting the CML stem cell comes. We know that alternate signaling pathways, the CML stem cells uses these to maintain itself and to develop resistance against the TKIs. These are the several pathways which are described in this figure over here. And some of these have now moved to the clinic. Some of them are in advanced stage of studies. Whole bunch of agents, right from chloroquine, hydroxychloroquine to arsenic to ruxolitinib, and of course our pioglitazone. And this is the concept of acting on the STAT5 pathway by using a PPAR gamma agonist. There is in vitro rationale that if you combine the TKI with PPAR gamma agonist pioglitazone, then through the STAT5 pathway, you kill more of the CML stem cells. This has been published in a small study of only 3 patients. These 3 patients were imatinib resistant, and when pioglitazone was added, they had a nice drop of the BCR-ABL, and in fact, one of them even went on to stop imatinib. He had that good a response. So this was a publication several years back, and we've done a small pilot study from our center. We are in the process of writing this up. We have presented it at 2-3 platforms. We used pioglitazone on an imatinib backbone in 15 patients, and except for this one patient, all the rest of the 14 patients has a nice response. So there is some science and some rationale to this. And I may want to tell you that I think Vellore is starting a ICMR-driven trial on the same combination, and several of these studies are ongoing in Europe. So innovative approaches and combinations, I personally truly believe that we Indians are great innovators, and once we get stuck, once we have our back to the wall, then we have to think of things like this. We've also done some, a little bit of research on traditional Indian medicinal plants and their anti-leukemic activity. This was again a publication in Leukemia. We were particularly interested in curcumin, and we found that curcumin in this CML cell line, K562 cells in the in vitro analysis, it did inhibit the growth of the cells. And if you added it to TKI, then there was synergy. We did a small clinical study, just quickly tell you that these are patients who were on imatinib, not doing well, BCR-ABL between 1 and 10, divided them into 2 groups. One received only imatinib, second received imatinib plus curcumin, and we followed them up for 12 months. And there was a numerical decline in the BCR-ABL, but this did not achieve statistical significance. And once we discussed this study with some experts, there's a gentleman who used to be in MD Anderson, Bharat Agarwal, who is one of the top people on curcumin in the world. And he told us that you were using too little of the dose of curcumin. So we've increased the dose of curcumin now, and we're taking this study forward. We're also particularly interested in this traditional Indian herb, ashwagandha, and there has been extensive research done by these 2 scientists, husband-wife team, Renu and Sunil, who work in Tsukaba in Japan. And they've done quite extensive work on ashwagandha. They have managed to identify the pharmaceutical active ingredient withanone and withaferin A. And they've also found that withaferin A, it blocks the ABL1 quite at the site where your ABL001 works, the asciminib, the new magic drug, which is at the moment is under testing. And we're on the threshold of starting a study with these people. And again, in a K562 cell line, they've demonstrated that if you combine ashwagandha with imatinib, then there is synergism in the suppression of the K562 cells. So we are wanting to take this forward. So ladies and gentlemen, there are some issues with access to TKI, and I quote the present president of the UICC, imagine for a second what it looks like and feels like to face a serious illness like cancer and not have the protection of universal health coverage. It's looking at someone and saying, the magic potion that will save your life is here, but not for you. So we face this situation many times when we have a patient who is resistant to imatinib. We know that we have nilotinib and dasatinib available with us, but we can't give that to our patients because of economic reasons. The Max Foundation has been helping us. You know that the GPAP program is run by the Max Foundation. They've provided 100 million doses per day across the globe. They cover 73 countries. And I was particularly interested in some data which we got from Pat Gonzalez, who is the CEO of the Max Foundation. This is the age of diagnosis in the 3 or 4 regions where they operate. This is the median age of diagnosis in the United States, and this is Africa, this is Asia Pacific, this is East Europe, Central Asia, and this is Latin America. So here our patients are 40 years old on an average. In the US, they're 60 years old. And this is the thing which really excites me, ladies and gentlemen. Look at the 5-year disease-free survival here, a 10-year disease-free survival here in patients who are on Gleevec. These are the poorest of the poor patients. Sometimes they get the medicine, sometimes they don't get the medicine. They are certainly not on optimal monitoring, but still the 5-year survival is in excess of 90%. So we must get the TKI into our patients, whether you monitor them or not. Of course, it is scientific to monitor them. It is better to monitor them. But the most important thing is make available the TKI to them and get the TKI to them, whether it's the 1st generation or the 2nd generation or the 3rd generation. So this is the lady I was talking about, the president of the UICC. The disparity of cancer care and survival between high-income countries and low-income countries is totally unjust, tragic, and unacceptable. And it is the sacred duty of each one of us to try and see if we can fix this. So take-home messages, finish in the last 2-3 slides. Prevalence of CML expected to increase to huge numbers, and we have to gear up to tackle this large number of patients. We need national guidelines and consensus statement. We are working on this. Hopefully in 2020, we will give you a consensus statement for a group of experts, which you can consult. We desperately need free subsidized access to 2nd, 3rd generation TKIs, and we need improved access to TKI. We need improved access to molecular testing, and we need more of the Max Foundation model in our country. So each one of you should try and do that. Innovative strategies for molecular testing, like the dried blood spot, which I told you could be a major advance in our country. We need to standardize our molecular labs. We need to think of innovative combinations. I showed you a few. That is still evolving science. I can't tell you that you should use that, but you may want to consider that when you have your back to the wall. And we need several more centers of CML excellence in many parts of our country, which can provide us reliable, affordable, BCR-able testing, kinase mutation domain testing. And ladies and gentlemen, we certainly need studies which are specific to our country. I already told you the massive number of patients which we are going to have in the near future. We need to think of some TFR studies in our country. And this is I think my last slide. So what we do in our part of the world is going to influence the treatment in the whole world. And I'm a member of this International Chronic Myeloid Leukemia Foundation, and the website is over here. This is a great organization to be a part of. If you have a CML patient who is not doing well, you can post that patient on this website, and you can have inputs from the top people in the world within 24 hours. So, you may want to note down this website, and you want to go there. There are lots of videos over there, much better presentations than what I have made to you today. which will increase your knowledge about CML. So this is the Indian CML group, which is in existence. You can see the who's and who of CML in this. Vikram Matthews is over here. Pankaj Malhotra is over here. Mohan Agarwal is here. Madam Neelam is here. Sandeep Shah is here. You know, everybody important is in this group. And we're trying to work together and see if we can, you know, standardize treatment in our country. This was a photograph which I took in 2002 when I was very young in oncology. This is a patient of CML who has a spleen this big in size and a quack as a part of treatment of this big lump in his abdomen, branded him with a red hot iron rod. And this is another different patient. So let's hope and pray, ladies and gentlemen, with the reign of oncology and hematology in young hands like yours, that this never happens in our country, and you never get to see this, what I can see Lalit over here, what Lalit and myself have seen in our time of practice. So like I've received funding for a little bit of work which you've done from these agencies, and this is my team over here. These are the lab people over here. And these are my clinicians. These two gentlemen are like faculty with me. And I'd like to thank them. Whatever little we've been able to achieve is because of these ladies over here. And these are some snapshots from ASH. I hope you recognize this gentleman. This is Dr. Kanti Rai and the CLL man. This is Dr. Nupur Raje, the myeloma person, and Dr. Ranjana Advani, Dr. Shaji Kumar. And one special privilege and pleasure at ASH was meeting all these friends. And this is like a funny photograph which I took there at ASH. And I think with that, I'll wind up. Thank you very, very much for your patient hearing. And I'll be looking forward to your questions now. Padmaj, will you take over now?
Hello. So there are questions in the chat mode. You would be able to see the questions.
Okay, let me see. How do I get
the first question is bone marrow aspiration and biopsy cytogenetics required in modern era of PCR? That's the first question.
My answer to that is yes, it is required. And why is it required? Bone marrow aspiration is certainly required because you should get a cytogenetics or karyotyping at diagnosis. And why is this essential? Because it will tell you additional chromosomal abnormalities which adversely impact on CML prognosis. So it's good to know that this patient is not going to do well. Secondly, if you can see early fibrosis in the bone marrow biopsy specimen at diagnosis, then again you have confirmation that the patient has more advanced disease and is less likely to do well. You may want to think of a second generation TKI up front. Next. But you will have to read them. I can't see the grid here. I can't see the questions, please.
Yeah, I can read out.
Thanks.
The second question is, can we switch over from second generation TKI to imatinib after achieving MMR? This is for financial reasons.
Okay, so that is a tantalizing possibility. You know, lots of people, I have thought of that. To the best of my knowledge, there has been a study from AIMS in which I don't know if there is somebody from AIMS who's on board, but they got funding for nilotinib for a lot of patients. Nilotinib was given to them till the patient achieved MMR, and then it was shifted, and the patient was shifted to imatinib. And they did not do well. Their preliminary results, of which I'm aware, is that the outcomes were not as satisfactory as they thought it should be. And at the moment, there is no data. But there is data that if you give the second generation TKI for a relatively long duration of patient, get the patient into deep molecular remission, have the deep molecular remission for about maybe a year or preferably 2 years, and then half the dose of TKI. This was a study presented year before last at ASH by Richard Clark. The Destiny study has been published in the Lancet Hematology now also. So that I think would be a better strategy to go to kind of get the patient into a deep molecular response, and then half the dose of TKI, maybe for 12 months. If the patient still remains in deep molecular remission, then you can do your TFR in that patient.
The next question is, what is the minimal dose of imatinib? Few lean thin patients, they do not tolerate 400 milligram of imatinib per day. So what is the minimum? Can we reduce the dose in such patients?
For every single patient of CML, whatever the body surface area, whatever the weight of the patient, you should start with 400 milligrams per day. And if there is a specific reason to reduce, either because of toxicities, either myelosuppression or non-hematological toxicities, then you can reduce. There are certain patients, and I think each one of us who has experience in treating CML, we have a bunch of patients in which they just do not tolerate 400 milligrams. They do not tolerate 300 milligrams. I have a couple of patients who are on just 100 milligrams of imatinib, and they are in deep molecular response. But to give you a quick answer, all patients should be started on 400 milligrams and reduced only if there is intolerance, whatever, either hematological intolerance or non-hematological intolerance.
Right. The next question is there a scope of addition of some other drug with imatinib for patients not able to go for second generation TKI in loss of molecular response? I think you talk about that in your talk.
There is another drug which I didn't mention, and regarding which some data is there, pegylated interferon. So PEG interferon plus TKI right at the start, or PEG interferon added for a patient who has a suboptimal response to imatinib. Those are options, but I would rather, PEG interferon in our country is very difficult to get now, and if the patient can afford the PEG interferon, I would rather switch them to a second generation TKI. Bosutinib is also not available, is also available now in our country, not very expensive. Generic dasatinib has been available since the past 1 or 2 months. So the generic field is opening up and becoming more exciting, and more options are there for our patients now.
Right. The next question is, what is the dose of imatinib for CML, BC, CML, AP, and PH positive ALL?
The dose of imatinib and the dose of second generation TKIs, if you choose to use them, is higher in these conditions. I would, for imatinib and a patient in accelerated phase, I would start with 800 milligrams per day, maybe 400 milligrams morning and evening. If the patient can tolerate that, wonderful. If the patient can't tolerate that, then you can come to 600 and try and maintain the patient on 600. Similarly, you have higher doses for nilotinib as well as dasatinib, 400 milligrams twice a day for nilotinib, and 70 milligrams twice a day for dasatinib if the patient has more advanced chronic myeloid leukemia.
Yeah. The next question is, what are the criteria? Is there any specific criteria for selection of second generation TKI? Tasigna or asatinib or bosutinib, or one or other?
For the newly diagnosed patient, or for the patient who is imatinib intolerant or resistant? Or should I talk about both?
It could be both. Yeah.
Okay, so for the newly diagnosed patient, if the patient is young and if the patient is a female, we are keeping economics aside just now. We are not kind of talking about economic. We are presuming that all the patients are affording. I would start this young female on a second generation TKI preferably nilotinib, and try and get a quick, deep molecular response, keeping in mind the fertility issues and the pregnancy issues and the family issues. Other than that, if I have a run-of-the-mill farmer who is a tough little chap, tough guy, who will have no problem in taking years and years of imatinib, I would put him on free imatinib and continue that for a long time. Now, once the patient, I would be less inclined to use dasatinib because the toxicities of dasatinib are a little more, I think, and I'm particularly frightened of the immunosuppression which happens with dasatinib and the odd and the funny infections which these patients get who are on dasatinib. Bosutinib is a relatively difficult drug to tolerate. I was part of the BELA trial, the first study which was done in India. GI tolerance is quite a problem. Significant diarrhea is quite a problem. So my choice of second generation TKI, first choice would be nilotinib, primarily because of the more targeted kinase inhibition and the better tolerability. If the patient progresses on imatinib, I would like to do a kinase domain analysis. It will show me something in about 50% of patients. And if I have a T315I mutation, then I would not use any one of the second generation TKIs. I would either think of getting ponatinib for that patient or sending the patient to a transplant. And between nilotinib and dasatinib, I would choose according to what the kinase domain mutation is. There are 4 or 5 mutations in which nilotinib doesn't work, but dasatinib works, and vice versa. 4 or 5 mutations are there in which dasatinib doesn't work and nilotinib works. So I would choose my second generation TKI according to what mutation the patient has.
Right. The next question is, any drug-free holiday period that can be recommended?
So drug-free holiday, I would suggest that you do that only as a TFR experiment. And I think all of our listeners, all of our young chaps would be very familiar with what are the inclusion criteria for a TFR. Otherwise, a drug-free interval, unless there is toxicity, unless there is a major problem in tolerating the drug, I would not consider that. That is, at the moment, not standard of care. Very little literature to support that. I am a believer and a fan of the halving TKI. So for the right patient in which you had a quick, deep response for an adequate duration of time, I would halve the dose of either one of the TKIs, imatinib, nilotinib, dasatinib, do that for a year, and then go on to a full TFR rather than 3 weeks on and 1 week off, or any other combination of drug holiday.
The next question is how to manage female on TKI with pregnancy.
So there was some little bit of confusion some years back. Now there is no confusion. The incidence of developing a stillbirth, having an abortion, or having a congenitally malformed offspring is about 10% if the patient is on TKI. So, and this happening in the general population is about 1%. So 10% is considered to be unacceptably high risk for continuation of pregnancy. So if you have a patient who's taking TKI, becomes pregnant, and you find out early in the course of the pregnancy, then what I do is I sit down with the patient and also the patient's husband. I counsel them about this 10% risk. And my advice is to the patient is to get a MTP done. And for the patient who is on TKI wanting to get pregnant, you have a different ballgame. Then, you would like to have a deep molecular response. You would like to have an adequate duration of the deep molecular response. And then you would like to, withdraw the TKI, keep doing the testing, and then permit the patient pregnancy. For fathering a child, there are no concerns. For a male who is taking imatinib or any one of the second generation TKIs, there are no risks for the baby if he fathers a baby. So there is a pretty clear recommendation on that. So you can, very comfortably permit that. Hello, are you there, Padmaj? Hello.
Hello, are you getting my voice, sir? Hello.
Could you hear my answer?
Yeah, I can hear you. Can you hear me now?
I can hear you now. I lost you for a few seconds, but now you're audible.
Yeah. Yeah. The next question is loss of molecular response with normal compliance, with appropriate compliance. And IRMA showed no mutations. So how to choose?
Then you can choose any one of the 3 second generation TKIs which are available to you. The comorbidities which the patient has will decide your choice of the second generation TKI. Say, for example, the patient has uncontrolled diabetes, or the patient has quite a significant amount of existing cardiovascular or cerebrovascular or peripheral vascular disease, or there is a history of pancreatitis in the patient, then you would prefer not to use nilotinib. If the patient is a patient of COPD, if the patient has bad lungs, if the patient has pulmonary hypertension because of any other cause, you would not prefer to use dasatinib. And bosutinib actually has less of comorbidity issues. So if the patient has bad heart and bad lungs, then maybe bosutinib would be the right choice. So if you don't have a kinase domain mutation which guides you in choosing your second generation TKI, then the comorbidities should guide you.
Right. What are the practical criteria for consideration of TFR?
So I have about 20 or 25 patients in whom I have attempted the TFR. I am very, very conservative in doing that. I normally like a total TKI exposure of more than 8 years and a deep molecular response of more than 3 years. And out of these 20 odd patients in which I've tried TFR, I've managed to have the patient remain in TFR 16 out of these 20. So my suggestion again to my younger colleagues is that if the next patient you see tomorrow, who's diagnosed CML 3 years back, who's been in deep molecular response for 1 month, 1 year, that patient is not a candidate for a TFR. So my again take is that with all the limitations which we have with regards to testing, with regards to the patient not coming every month for the testing, which is absolutely mandatory, go conservative, choose your patient very, very carefully. And if the patient is on a second generation TKI, wanting to stop because of economic reasons, try the half TKI or the Destiny module, and then go to the full TKI. So does that make sense?
Yeah, it is, sir. Yeah, but the next one is, do you recommend sperm cryopreservation before starting imatinib in young males planning fatherhood in near future?
Absolutely no. They can, the incidence of testicular toxicity, spermatic toxicity, incidence of infertility with the TKIs, all the 4 TKIs is not very well described. So there is absolutely no need for that expensive procedure.
The next question is your personal experience on stopping TKIs. I think you just mentioned about
I just mentioned that, yeah.
Yeah. The next is breastfeeding during TKI treatment.
Absolute no, TKI is secreted in the milk. So if you have a patient who is lucky enough to conceive and deliver a normal baby, then they get top feeds, no breast feeds. If the patient is in deep molecular response, and you can still delay reinitiating TKI for another 6 months or maybe 3 months also, if the mother can get to breastfeed the baby for 3 months also, and then you can restart your TKI, that is also fine. But if the patient is taking, if the young mother is taking TKI, then absolutely no breastfeeding. The TKI, all the 4 of them are secreted in breast milk.
Okay. The dose of various TKIs in childhood CML, management of childhood CML. I think management will be too exhaustive to cover, but we can probably just mention in brief.
Well, I actually am not very sure about the per meter square dose. It should be easy to check. But I do want to convey that all the 3 TKIs, imatinib, nilotinib, and dasatinib, are now approved for use in pediatric setting. My experience with pediatric patients is that they tolerate the TKI very well. They do have some growth issues, so you have to very carefully monitor their growth. And you should be more aggressive with calcium and magnesium supplementation in the young and the adolescent patient. And you should be more aggressive about stopping the TKI, so get them into a quick remission by one of the more stronger 2nd generation TKIs, and in 5 or 7 or 10 years, get them off the drug. There are very few studies of TFR in young patients, but there are a few studies, and the same principles hold true, which hold true for adult TFRs. So my feeling is that rather than giving somebody, say, a 14-year-old patient or a 16-year-old patient a TKI for 30, 40, 50 years, and get the patient into a deep molecular remission and think of a TFR in maybe 10, 12 odd years. And my apologies for not remembering the doses off my head, but it should be easy to check.
Right. The next is how to counsel young female eager to conceive.
So I think we did deal with that just now. You have to very categorically tell one that there is a 10% chance of a fetal malformation if you continue to take the TKI and get pregnant. Follow a foolproof way of contraception. Either if the family is complete, then do a permanent thing. If the family is not complete, then do a temporary thing, but do a foolproof thing. Getting an MTP done again and again is not something which is very desirable. It is mentally traumatic to the patient also, and preferable to use a 2nd generation TKI in these patients so that you get a quicker, deeper response, and you can think of a TFR earlier rather than a little late.
Yeah, there are 2 questions which are almost similar. What is the adequate time period before conceiving, and when to conceive after stopping imatinib?
So if you give a 3-month TFR free period, then it is fine to conceive. The blood is completely washed out of the system in 1 month time. And if you play safe and permit attempted conception after 3 months, that's fine.
Right. The next question is, can we consider interferon in pregnant lady who has CML and needs treatment?
So very recently I did that. There was this young lady who was pregnant and then diagnosed with CML. So we gave her interferon. It didn't work very well. Her counts continued to remain around 1 lakh. Didn't dare to give her a TKI, didn't dare to give her hydroxyurea. So we just went ahead with interferon counts did not increase. So between 50,000 and 150,000, the counts remained. And then she delivered a normal child, no complications during delivery. And immediately post-delivery, we started the TKI, did not permit her to breastfeed. So interferon is an option for a patient who is diagnosed with CML and is pregnant, and also an option in a patient in which you are attempting a TFR in the hope of permitting the patient conception, and the patient has a molecular relapse. Then also you can tide over that 6, 8, 10 months with interferon. And then if you have an emergency in the sense that the patient is, the CML is rapidly progressing in the sense that the BCR-ABL is rapidly increasing, counts are rapidly increasing, then if you permit that 3-month period, the first trimester, if you don't give them TKI and start TKI in the second trimester, that is much better, much more acceptable than giving them TKI in the first trimester where organogenesis is happening for the fetus.
There's another extension of this question. What if there is a loss of disease control during pregnancy, management by trimester, first, second, or third trimester?
So we just discussed that interferon is a good bridge. And if there is rapid progression of the CML, if you feel that the BCR-ABL is very rapidly increasing, the counts are very rapidly increasing, then you somehow manage the patient during the first 3 months, the first trimester, and in the second trimester, of course, with all the documentation, you can start the TKI with much reduced chance of problems.
Right. I think this is the last question, and then there is a comment. The last question is about imatinib renal toxicity.
Yes, this is coming up in the past few years. There has been a gradual decline in creatinine clearance in patients who have been on imatinib for a long time. So what I've started to do is that every 3 months or 6 months, I ask for a serum creatinine. I have about 300-400 patients of CML under treatment, and I haven't seen any major increase in creatinine. So it is being described as a potential long-term toxicity, but I think from a practical and a pragmatic point, it is not of very much magnitude and possibly not of very much clinical significance. But I would suggest that for patients who've been on imatinib for a long period of time, you do get a creatinine done every 3 monthly or every 6 monthly. You do advise them not to take nephrotoxic treatments. Say, for example, avoid non-steroidal anti-inflammatories for pyrexia and other myalgias and body aches. Just stick to the safer paracetamol. Be particularly careful when there is volume loss, when it is very hot, when they have diarrheas and vomitings, to make sure that hypovolemia doesn't happen. These are the few things which you can do, but it is not a huge issue.
All right. I think that gets us to the end of this session. Before that, I just want to read a comment by Dr. Lalit Mohan Sharma. He has conveyed, Professor Malhotra, excellent talk and refreshing the concepts of management of CML in resource-limited settings. And he has thanked me, thanks to Dr. Padmaj, from bringing this to us. We love more meetings like this.
Thanks, Padmaj. I enjoyed this, and I hope everybody else did too.
Yeah, thank you very much, sir, for being with us and talking to all of us. I think we had about 80 people today who benefited from your talk, and we hope to have more in coming times. Thank you very much, and have a good night.
And I would love to have feedback from whoever participated and how we can make this even better. Thank you very much. Really enjoyed myself.